I want to thank CSTE for the opportunity to speak to you this morning on the topic of making gains on hepatitis C. I think I would actually like to retitle it also, and this might be making gains on a moving target. I have slides that I think are current at the moment that'll probably be obsolete by the time I finish, which is a reflection on how quickly things are changing, not on how long I plan to talk. Hepatitis C is a really excellent, specific example, not only of some of the public health concepts that we just heard about, but also as a follow-on to yesterday's plenary session. I think it may be, more than any other, an area where there's the need to bridge that Martian chasm that Dr. Fleming described between public health services and clinical services. I'm going to start with a quick review of the essential public health services and a challenge, particularly for those of us from the West whose biologic clocks are ringing about 5 or 6 right now. It'll maybe help keep us awake. As I go through the presentation this morning, much of which will be informational, I want you to look for the 10 fingerprints of the essential public health services. It'll be a bit of a public health Where's Waldo that'll help us all stay awake. I'm going to start with just a quick review of the virus and the disease itself. Many of you are aware or maybe even participated in a celebration at CDC this past week for the 25th anniversary of the identification of the hepatitis C virus as the cause of what had been previously known as non-A, non-B hepatitis. It's a flavivirus related to yellow fever and West Nile virus, some of our other favorites. Some of the characteristics are there. I think one piece of news that'll be interesting to follow is what's going to come out of some of the virologic studies of the non-primate Hepativirus or Hep C viruses that have recently been discovered. That's the genus that hepatitis C virus is in, and it may tell us more about how this virus became established in the human population. It's fairly unique in its high rate of viral production, and clinically that translates into very high viral loads. It's not uncommon to see patients with more than 10 million virions per cc of blood. Genetically, it's pretty simple, a single reading frame that translates into 3 structural and 7 regulatory proteins. This provides lots of opportunities for antiviral drugs. The RNA polymerase lacks proofreading capacity, which is actually important. It leads to frequent mutations in a lot of quasi-species. It means that it's difficult to establish lifelong immunity. It's also a challenge to treat with single antiviral agents because of emergence of drug resistance. The good news is there's no proviral state. So the virus is not incorporated into the host DNA. It's right out there in the cytoplasm, just daring you to come and eradicate it. There are 7 genotypes, epidemiologically important because they're geographically clustered, clinically important because they are associated with treatment response. In the United States, genotype 1 is by far the most common, accounting for about 70% of infections. Most of the remainder are genotype 2 or 3 with just a few genotype 4s. We follow 1,300 HCV-infected patients at the Alaska Native Medical Center, and I think we have less than 10 with genotype 4. There are a large number of subtypes, and while genotype is associated with treatment outcome, it's not associated with disease severity. Manifestations of acute hepatitis C occur after an incubation period of about 6 or 7 weeks. The course is typically very mild. Looking back at some of our patients, they never had jaundice, but they maybe came in and they were pretty sick enough that somebody drew blood. And their transaminases were elevated maybe in the 60 to 80 range, not high enough that someone said, oh my gosh, it's hepatitis. And they were signed out as viral syndrome, which was correct, but fairly nonspecific. Only about a quarter of patients actually present with jaundice. HCV RNA can be detected in the blood as early as 1 to 2 weeks after exposure, and antibodies don't develop until about 2 to 3 months later. The majority of people who are acutely infected will go on to develop chronic hepatitis C, which is one of the major reasons why this is such a challenge to public health and the healthcare system. Chronic hepatitis C is defined by isolation of HCV RNA in the blood in 2 specimens collected at least 6 months apart. The natural history of hepatitis C is on this slide, not that slide. As I mentioned earlier, the majority of people will be chronically infected, but there are a minority in the literature described generally as 15 to 25% who will spontaneously clear the virus. But clearance is much more common among certain people, such as those who are younger when they're infected. It's more common among females, more common among people who are the IL-28B CC genotype. IL-28B is an allele on chromosome 19, which is a determinant of response to interferon, whether it's endogenous interferon or exogenously administered interferon used as part of therapy. The IL-28 genes, there's the CC genotype's the good one, TT is the bad one, CT is kind of in between, do tend to cluster in racial groups, so spontaneous clearance is highest among people of East Asian ancestry and lowest among people of African ancestry. Spontaneous clearance is higher with normal immune function. And interestingly, that patient who actually comes in really sick and jaundiced is more likely to clear the virus than those who have mild manifestations. The majority go on to develop chronic HCV and have a smoldering hepatitis, which will oftentimes lie fairly quiescent, asymptomatic for years to decades. But unfortunately, the typical course among all people who are infected, about 10 to 15%, will go on to develop fibrosis and cirrhosis. And there's a number of factors that increase that risk of progression. And they're primarily things that stress the liver. So alcohol consumption is a huge one. Infection at a later age also plays a role. So in addition to inflammatory insults to the liver, things that encourage cellular aging, such as aging, appear to play a role as well. I don't have a good explanation for the more rapid progression in males, but HIV co-infection is a huge factor in progression, and that again ties back to cellular aging. In fact, among people who are HIV co-infected by 20 to 25 years, more than half will have progressed to fibrosis or cirrhosis. Hepatitis B co-infection also is associated with more rapid progression. And high body mass index, and here's an overlap with something Sten mentioned about non-alcoholic steatohepatitis, that we do find that patients with fatty livers are more likely to progress. Unfortunately, once fibrosis and cirrhosis are present, the progression is fairly relentless over the next 5 to 10 years to end-stage liver disease, which in the absence of liver transplantation may lead to death. 1 to 4% per year of people, once they have cirrhosis from hepatitis C, will develop hepatocellular carcinoma. If Waldo's not working for you, have a cup of coffee, and if you have hepatitis C, have several cups of coffee. Several epidemiologic studies have shown consistently reduced risk of progression to fibrosis or cirrhosis with greater coffee consumption, particularly 4 or more cups a day. Less consistent association with other caffeinated beverages. Recently, it's been proposed that the molecular mechanism for that action by caffeine may be through direct action on the hepatocytes. Moving on to the epidemiology, chronic hepatitis C is truly a global challenge. In fact, the rates of infection are probably lowest in the US, Canada, Brazil, and Paraguay compared to the rest of the world. The country with the highest rates is Egypt, where nearly a quarter of the population is infected. This is an iatrogenic effect of anti-schistosomiasis therapy, which was through injection and was administered at the population level from the late 1950s until the 1980s. Unfortunately, infection control practices were not adequate to control the risk of bloodborne pathogens. Altogether, about 3% of the world's population is chronically infected. That's over 185 million people. HCV is thought to contribute to about 500,000 deaths a year, and 3 to 4 million new infections occur in the world each year. Not sure what I'm aiming at, but Here in the U.S., the NHANES data gives us a good handle on the infection rates in the U.S. This slide shows the rates of antibody reflected by the white bars and HCV RNA reflected by the blue bars during the last 3 NHANES surveys. I think I would summarize it by saying we've got about 3 million people in the United States with chronic HCV infection. But as we heard yesterday, many health events and health risks are not evenly distributed in the population, and that's true for hepatitis C also. You're looking at the NHANES data, the rates of infection are higher among people who are middle-aged. You made everybody raise their hand if they were over 60, 50 to 59. About 3% have chronic hepatitis C infection. Rates of infection are higher among males, among non-Hispanic blacks, higher among those with lower education level, higher among those whose family income is less than twice the federal poverty level. And the real take-home here is intravenous drug use. The rate of infection, the prevalence of infection among people who report more than just marijuana use as a recreational drug activity is over 5%. This creates a burden on the U.S. healthcare system. A very recent analysis of multiple discharge databases reflect that among people that were born between 1945 and 65, inpatient hospitalizations for those who are HCV positive has increased more than 60%. And the hospitalizations in that group for liver complications cost more than $6 billion annually. And in that age group, less than half of these patients had private insurance. The impact on cancer is fairly great. When we look at the SEER database from NCI, 5-year rate changes in mortality from 2006 to 2010, there's many things to celebrate in terms of falling rates of cancer mortality. The one outlier that shows mortality rates increasing by more than 1% per year is cancer of the liver and the bile duct, which likely is being driven primarily by hepatitis C infections. During the past decade, the mortality from hepatitis C has been increasing, and since 2007, more Americans have died of hepatitis C infection than have died of HIV. Transmission of hepatitis C. It occurs in both healthcare and community settings. I think if I were giving this talk, last year, it'd probably be different. But 25 years ago, it'd be very different. We'd be talking about healthcare setting transmission. And one of the big risk factors among people who are in that baby boomer cohort is blood transfusion before donor screening was instituted in July of 1992. My clinic last week, I saw 2 patients who've had HCV for more than 30 years now, no other risk factors than having received a blood transfusion in the early 1980s, and they're now being evaluated for treatment. Also, risk factor was receipt of clotting factor concentrates before heat inactivation, which was done for HIV in 1987. Needle sticks are a risk. If you remember your rule of 3s, average risk from HCV is 3%, so it's greater than the risk of transmission of HIV, but less than the risk of transmission of hepatitis B. More recently, though, in healthcare settings, we see challenges from unsafe injection practices due to drug diversion and lapses in infection control practices. Much of the transmission today occurs in the community. The top 3 factors are all intravenous drug use. There are other modes of transmission. Perinatal transmission occurs. The risk to an infant born to a mother who is HCV positive is 5%. That risk increases to 5 to 15% if the mother is HIV co-infected. Fortunately, there is no risk of transmission through breastfeeding. There's also good evidence of transmission through traumatic sexual acts leading to blood exposure. Consistent finding in the EPI studies is a higher risk among people who have multiple sex partners, particularly among men who have sex with men. It's very likely that transmission could also be facilitated through genital ulcerative disease. Other risk factors that can lead to blood exposure through the mucosa or skin include intranasal cocaine use, sharing of razor blades, and unregulated tattooing and body piercing. The one venue where many of these risk factors coalesce is in prisons, and a number of studies have shown that anywhere from 25 to 50% of people who are incarcerated are infected with hepatitis C. I show this slide just as an example of a jail tattoo. I've actually had some patients who have some pretty spectacular tattoos that they got while in prison. And of course, this all happens out of the sight of the guards. And the tattoo inks are sometimes ink pens, ground up pencil lead. They use soot, mix it with shampoo. I mean, there's some very imaginative things that are done. But I always sort of talk with patients for an extended period and try to get a history of whether or not they've ever been incarcerated and what happened when they were in jail. Intravenous drug use is something that's been with us for quite some time. It's interesting to see how the story of Sherlock has evolved from the original books in the 1890s when Sherlock kept his morphine on the mantle and would inject when he was needing to come down a little bit, to today on the TV show where he struggles with nicotine addiction. There was recently a meta-analysis of multiple national surveys to get, I think, probably one of our best handles on the epidemiology of intravenous self-injection drug use. 2.6% of the population aged 13 and older in the United States report at least one time self-injection drug use, which translates into 6.6 million people. And a third of 1%, or nearly 750,000 people, report injecting during the past year. The lifetime risk of injection is highest among people aged 35 to 64. And I think what's most remarkable is at the bottom of the slide is that the HCV injection rate among persons aged 40 to 65 with lifetime use, at least one time, is 43%. And that's not an uncommon scenario. I have a number of patients who I've developed good relationship with. We have really dug into possible risk factors. And it kind of comes down to that one party in college back in the 1970s where they experimented, tried it, didn't like it, never did it again, and all evidence points to a long time infection with hepatitis C virus. Intravenous drug use may be driven by increasing use of heroin. There's a lot of speculation about whether or not this is an untoward effect on increased regulation of prescription opioids. I put this quote at the bottom in because this is something I hear all the time, and I think it's something that's happening nationally. This is from a letter to the editor in the New England Journal, which quotes a patient. Most people I know don't use OxyContin to get high anymore. They've moved on to heroin because it's easier to use, much cheaper, and easily available. I had one patient even comment that he thought it was cheaper than cigarettes. This has influenced the epidemiology. This slide shows the proportional age distribution of newly confirmed cases of HCV published by our colleagues in Massachusetts. 2002, that curve looks kind of like what you'd expect with the hump in the baby boomers, primarily people in their 40s to early 50s. By 9 years later, the distribution had changed. You see aging of that cohort that was infected earlier, but you also see the emergence of a new cohort of people in their 20s. And much of that, I believe, is being driven by intravenous drug use. A question I get quite often in the clinic, more than in the public health setting, is heterosexual transmission of HCV. The virus is present in very, very low titer in genital secretions, so it seems like the risk would be relatively low. At least a number of epidemiology studies have been done. One cohort study, multi-year study of 500 monogamous HCV discordant, HIV negative heterosexual couples estimated the transmission risk at 0.07% per year, or about 1 in every 190,000 sexual contacts. So you could have sex every day for the next 520 years, I suppose. In that study, transmission was possibly associated with intercourse during menses or anal receptive intercourse by the HCV negative woman, but those were not statistically significant. The CDC currently does not recommend routine condom use in this setting of a monogamous relationship where the HCV infection is discordant. Outbreaks occur, unfortunately, still today. I want to move through this one fairly quick, but this was a cluster of 3 cases among patients who'd received organ transplants, so they had pre-transplant screening. The viruses of the 3 patients were highly related by sequencing. Epidemiologists went back and using that exposure period or the incubation period, developed a presumed exposure period and intensively reviewed the medical records. They found that all 3 of these patients had received fentanyl in the interventional radiology suite during the presumed exposure period. 21 employees had worked in the radiology suite. Somebody suspected something was going on. All had submitted blood for HCV testing, and one, using EpiSpeak, radiology technician A, was PCR positive for genotype 1A. On the right-hand side of the slide, you see a graphic representation of the sequencing showing more than 96% homology with the 3 patients. They're all over there. The other clouds of quasi-species are NHANES participants as controls. After several interviews with both public health and law enforcement, as you can imagine, RAD-A admitted that he had diverted and self-injected fentanyl intended for patients by 2 methods. One was retrieving the syringes containing residual fentanyl from the sharps container and injection after work hours. Not very smart for his own health, but from an infection control standpoint, apart from the tech himself, okay. But he also reported that he would replace the needle on pre-filled syringes with a smaller gauge needle, sneak it out of the suite, self-inject while at work, replace the original needle, and refill the syringe with saline, then returning it to the patient care area. Not only not good for anesthesia in the interventional suite, but also a big infection control risk. This graphic represents what was happening if you replace the HCV-infected patient in the middle there with RAD-Tech-A. When he would self-inject, like anybody trying to find a vein, he would withdraw. This would draw blood back into the hub of the syringe. As we move across there, he would dispose the needle, thinking that was going to be a safety measure, not aware that the syringe was contaminated. The syringe would then be used to administer drug to subsequent patients. Certainly would have the risk, if that were then used to withdraw from multi-use vials, further transmission. Unfortunately, it's not an isolated incident, although some healthcare-associated outbreaks are related to knowledge gaps. A good example was a pain clinic in Oklahoma. Great cost-saving idea, just fill large syringes with fentanyl and propofol to treat many patients, and you could reuse the syringes because you're just injecting through Hep blocks. Ultimately, 71 cases of HCV and 31 cases of hepatitis B were associated with this practice. During the 5 years from 2008 to 13, 18 healthcare-associated outbreaks were reported to the CDC. And these occurred in a variety of settings, not only inpatient units, but also long-term care facilities, hemodialysis units, and clinics, including alternate care clinics, including at least 1 acupuncture clinic. These outbreaks have led to 223 outbreak-associated cases and created a huge burden for public health as well as health administration and risk management, with over 90,000 at-risk persons needing to be notified for screening. So a lot of work for those of us in health and a lot of opportunity for others. Interventions to prevent transmission and disease progression, screening to identify infected persons. And this is one of the areas that is probably most important to fill what I'll call a void that is currently full of fatalism. I hear frequently, why do we need to screen? Because there's nothing we can do. Even before treatment was effective treatment was available, we still found benefit from screening patients and staging them so that we could particularly watch for hepatocellular carcinoma and intervene appropriately. We also need to provide effective and curative treatment before onset of fibrosis or cirrhosis. One of the fun things about my day job at Alaska Native Tribal Health Consortium is I get to work at this tribally administered nonprofit health corporation, where we actually are able to somewhat integrate our healthcare along with prevention services in partnership with the Alaska Division of Public Health. And then finally, reducing the risk of exposure through prevention and treatment of chemical dependency, which sounds easy, and I think we, in public health particularly, need to move upstream a bit into areas that are totally unfamiliar to us and begin to answer the question, why do people need to self-medicate? I think we still struggle with a sort of 19th century mentality that people abuse drugs because of some sort of moral flaw. And I think we sort of need to all say to ourselves, but for the grace of God, there goes every one of us. And we need to look at what are the societal and personal traumas that create this need to self-medicate. And I think when we start talking about things like adverse childhood events, that's when we begin to get into control of some of the issues we face with self-injection and the infectious complications from self-intravenous drug use. Needle exchanges have been shown to be effective, and I would stress we need to think in terms of not just needle, but needle and syringe exchange. And finally, promoting self-injection practices in healthcare settings. I think everybody here is fairly familiar with the CDC recommendations for HCV screening. 2 years ago, they were expanded to include everyone born between 1945 and 65, so everyone age 49 to 69 who's not already had it should have a one-time screen if there are no other risk factors. And of course, anyone who's HIV infected should be screened, as well as anyone who's ever injected illegal drugs. The screening is a lot easier than it used to be. If you're in the back of your mind scratching around trying to remember what the Reba test was, just let that neuron die because it's gone, and none of us are going to miss it. There's much better antibody tests now. If that screen is negative, the patient doesn't have hepatitis C. If there's ongoing risk, they should be tested again in the future, of course, because you could be in that window period. So for instance, with a needle stick, I routinely do a baseline 2-month and a 6-month follow-up. If the antibody test is positive, there should be a test for HCV RNA. If it's negative, there's no current infection. You can reassure the patient if there's no ongoing risk. They're very fortunate. They have ducked a bullet. If it's positive, the patient has chronic hepatitis C, and particularly if that test is still positive 6 months later. That's actually the definition of chronic hep C. At that point, they need further evaluation. They should, when it's initially positive, I think they should have an HIV screen, but they should also be screened for immunity to hepatitis A and B, and funneled into care that's appropriate for hepatitis C patients, although that's one of the areas that I think may be changing rapidly in the future. This may be the most important slide in terms of where we failed. This represents the proportion of HCV-infected persons who are screened, referred, confirmed, and treated. John Ward calls this the failure of the Cascade of Care. And what you see is, starting over on the left-hand side, about 3 million Americans who are infected. Only about half have been screened to even be aware of their status. What I think is really tragic is then the middle part of the slide. When we move from the proportion who are screened to the proportion who are referred to care to the proportion that have their antibody test further evaluated with an RNA test, only about half of those who have antibodies have actually had the confirmatory RNA test. That is really a tragedy. The proportion that go on to treatment is currently fairly low, and there's some medical reasons for that, as well as some failures in the medical care system. Fundamentals for safe injection practices include remembering that needles and syringes are single-use devices. The use of right-sized vials and pre-filled syringes is preferable to minimize drug wasting, and single-use vials should never be used to administer medications to more than one patient. That's why they're called single-use vials. The Safe Injection Practices Coalition is an efforts led by CDC, ASTO, SHEA, a number of the state health departments here in the room, as well as a number of professional societies to get that word out. And I have to say, one partner that I haven't seen on the list yet that I hope to see soon is the American College of Healthcare Executives, because oftentimes it is the C-suite that begins driving some of these practices that increase the risk of transmission. Treatment. The goal is cure. I don't think I have time to do an Univision style pronunciation of goal, but I would love to during the World Cup. Cure is defined by a sustained virologic response, and SVR12 is very specific, at least in FDA language, as undetectable HCV RNA 12 weeks after the end of treatment. And that's now accepted by the FDA as a definition of a cure for new drug approval. The benefits of SVR are huge, and this is another area where I find there's quite a gap in knowledge among some of our clinical colleagues. There's been a meta-analysis of observational studies that show a dramatically reduced risk of hepatocellular carcinoma among people with chronic HCV who achieve SVR. And keep in mind, they're not really at risk of hepatocellular carcinoma until cirrhosis is present. So we're talking about people who are way down that disease progression, if you go back to that natural history slide. An analysis of the VA clinical registry also showed reduced disease progression by several outcomes, including cirrhosis, decompensated cirrhosis, liver-related hospitalization, and mortality, including all-cause mortality, which kind of makes you scratch your head, what's going on there. I'm not sure how correct this is, but I think it's fairly correct that chronic hepatitis C is somewhat like periodontal disease. It's a chronic inflammatory state that has a number of systemic manifestations, and that's why we see things like higher rates of cardiovascular disease among people with chronic hepatitis C and among people with periodontal disease. Treatment, I won't go into a lot of detail, but this is some of the reasons why people have been somewhat fatalistic. Very low SVR rates with ribavirin-based therapy. Even 10 years ago, when the state-of-the-art was pegylated interferon, pegylation reduced the need for injections 3 to 4 times a week to just weekly, was fairly toxic, and for our most common genotype, SVR was achieved by less than half the patients. Interferon's no fun. I think this room is fairly sophisticated in terms of knowing the difference between the flu, meaning viral syndrome, and real influenza. And if you've had real influenza, you know that hit by a truck feeling, you know it messes with your mind. That's the interferon response your own body is making. And just imagine doing that for nearly a full year. We've successfully treated a number of patients using this regimen, particularly the 24-week regimen for genotypes 2 and 3. We get about 70% of the patients through that regimen, but about a third end up on antidepressants. Excuse me for a moment. And I'd like to thank the moderator for 10 extra minutes to present. But treatment really began to change in 2011, and I'll make 5 minutes, don't worry. That's when the first direct-acting antivirals were approved, 2 protease inhibitors, telaprevir and boceprevir. They were approved for genotype 1 only in combination with interferon and ribavirin for still a long course, 24 to 48 weeks. But now, for the first time, we're starting to see more than half the patients with genotype 1 achieving SVR. It was no fun, though. I think we ended up stopping attempting this therapy after about a dozen patients. Not only did you have the interferon and ribavirin effects, but telaprevir and boceprevir were fairly toxic. The term firea entered the medical vocabulary for the first time, the combination of diarrhea with very intense rectal pain and itching. But late last year, the next generation of direct antivirals emerged. Cimeprevir, which is a protease inhibitor, it's a much less toxic version and more effective version of the same class as telaprevir and boceprevir. And sofosbuvir, which was the first nucleotide analog polymerase inhibitor. And now things are starting to look a little different. For genotype 1, we're looking still with interferon-based therapy, but for only 12 weeks. For genotype 2, 12 weeks that's interferon-free. Genotype 3 is the new one in that it still requires longer courses of therapy, but interferon-free therapy is indicated. The pipeline, I think, is loaded with new antivirals. It reminds me very much of the story with HIV back about 10, 15 years ago. In working with patients, it's really exciting because it reminds me of the early 90s when we first began talking to patients about the possibility of suppressing viral load and controlling infection. In this case, we're talking about cure. And there's nothing more exciting whether you're wearing the clinical or public health hat to see someone begin to cry and say, I thought this was going to kill me. I thought this was going to affect my baby. I've not had any more children because I'm so scared of this virus, and to be able to talk to them about actually curing it. Currently, there are the 4 medications that are FDA approved. I think the next big thing will be the combination of ledipasvir and sofosbuvir. That will be a 1 pill, 1 time a day. And the preclinical data looks really good. This is summarizing 2 papers that were recently published from preclinical trials. Bottom line is ledipasvir and sofosbuvir, with or without ribavirin, 24 weeks, 12 weeks, 8 weeks, all of them had SVR rates above 90%. There is a dark side to that. The retail cost for a 12-week course of sofosbuvir is $84,000. Like these folks did the math, you can too, that comes down to $1,000 a pill. That actually creates some challenges in terms of making sure that patients don't lose their medication and managing it well. If you've seen Dallas Buyers Club, you know, we need to make sure people aren't trying to share their medications to take care of their friends who might not currently be receiving treatment. So this is going to be a huge challenge to address. I'd like to be optimistic. I'd like to think Ghana and Portugal are going to draw, and it doesn't matter how we do against Germany. And I'd like to think that as additional drugs become available, market forces will bring the price down. But I think we need to push for that to happen, and that the drug is available widely. As I mentioned earlier, many people who are infected depend on public sources of support and health insurance, so this is a huge burden. If we treated, just back of the envelope calculation, if we treated every American infected with chronic hepatitis C, right now the retail cost for sofosbuvir alone would be $350 billion. That's 10% of what the entire federal budget was last year. So in closing, areas of controversy and ongoing change is cost and cost effectiveness of direct-acting antivirals. This is not a no-brainer. Yeah, liver transplant is very expensive, but the medications are very expensive also. And I'm pleased to see that people who are much smarter than me about health economy are doing these kind of analyses, and these should be out soon. I think we need to be involved in not only, I know a number of people in the room are working on pressuring the manufacturers to bring the price down, but we also need to work with the third-party payers. And the message is that they need to not be confused by the term chronic HCV. They're thrown off by that word chronic. They're thinking hypertension. They're thinking diabetes. In this case, we're talking about drugs that cure, not just things that begin a lifetime of treatment. I think we'll learn a lot more about the role of mandatory testing laws, which the first one in the country was instituted in New York State in January of this year. I have no idea what the impact of that is going to be, and perhaps that's a topic one of our colleagues would like to address during the discussion. Another controversial area is treatment of actively self-injection drug users. We don't do that in our clinic right now, primarily because of loss to follow-up. I like the term you used for the patients who drop out of cancer treatment in Africa, because I think that's a very similar situation to what we see among our active users rather than non-compliance. The goal would be to reduce subsequent transmission, as has been shown with antiretroviral therapy and HIV infection, but it will require new approaches. And some of these newer drugs really do open the possibility, particularly as we move away from interferon. We have completely oral therapy. Some of the new preclinical trials are looking at courses as short as 4 weeks. So it is indeed feasible to do directly observed therapy, such as providing meds at methadone treatment centers. We need to know more about the optimal treatment of acute hepatitis C and about the role of post-exposure prophylaxis. So in conclusion, hepatitis C chronically infects roughly 3 million Americans. Many are unaware of their infection, as was the typical HCV patient, if you'll forgive that term, is like the patient that was described to us yesterday. They're medically and socially complex. Oftentimes they're marginalized and or have limited access to health care. After years of chronic infection, the disease will progress to liver disease and ultimately to death. Transmission continues today, mostly through self-injection drug use. It is preventable and curable, but it creates new challenges to public health, healthcare, and healthcare financing. And the biggest challenge we need to overcome is the fatalism, particularly that I hear among our clinical colleagues. They used to say, why test because we can't treat? Now they say, why test, we can't afford to treat. And I want to acknowledge my colleagues at ANTHC as well as the Alaska Division of Public Health, and thank you.